So in today's video, I pull apart Dr. Greger's SIBO testing claims. Roll the titles.
For the record, I'm done trying to make y'all comfortable. For the record, you ain't trying to grow, then it's done for you.
Gastrointestinal symptoms like abdominal pain and bloating account for millions of doctor visits every year. One of the conditions that may be considered for such a non-specific presentation of symptoms is SIBO, small intestinal bacterial overgrowth.
OK, so that paper Dr. Greger put up on screen, let's just quickly have a review of it. So that paper was published in the Mayo Clinic Proceedings in 2016. The Mayo Clinic Proceedings is sponsored by the Mayo Clinic and has been publishing since 1926. The journal contains Nobel Prize-winning research and has an impact factor of 6.9 out of 10, so it's certainly more credible than some of the previous journals and publications that Dr. Greger has cited on SIBO. All of the authors who contributed towards the paper are practicing gastroenterologists, and just a quick note that this publication is a primary care review and not a clinical trial. So the authors simply looked at the available evidence at that period of time in 2016. We are now in 2021, so this review is 5 years out of date, but this is what the paper concluded. Small intestinal bacterial overgrowth is a clinical syndrome caused by the pathologic proliferation of colonic-type bacteria in the small bowel, usually seen in patients with predisposing conditions. This can lead to non-specific GI symptoms, leading patients to seek medical care from their primary care providers. There is a lack of agreement on the diagnostic and treatment approaches, but there are options available, and an approach is outlined in Table 2. In the community setting, empirical treatment trials and breath testing are potential options. In larger healthcare settings, small bowel aspirate is available as a definitive test, but comes with higher cost and risk. Regardless of the diagnostic approach, the foundation of treatment is the conscientious and discerning use of antibiotic therapy, along with eliminating or altering predisposing risk factors as able. So you can see in the first study that Dr. Greger put forward there is a consensus that SIBO is a legitimate problem, and that you can use breath testing or biopsies to diagnose. Biopsies are obviously less preferential because of the costs and risks associated with them. So let's see where Dr. Greger goes from here.
A concept that has gained popularity on the internet, in addition to certain clinical research circles. SIBO is broadly defined as the excessive growth of bacteria in the small intestine.
Correct, and I just want to bring the video back to the last video in Dr. Greger's series, because you just heard Dr. Greger say that SIBO is broadly defined as the excessive growth of bacteria in the small intestines. In Dr. Greger's fiber versus low FODMAP, he said this about SIBO.
It turns out it's not the number, but the type. It's the kind of bugs you have growing in your small intestine. So it's small intestinal microbial dysbiosis, not overgrowth in general, but the wrong kind of growth.
So which is it, Dr. Greger? Is it an abundance of bacteria in the small intestines, or is it dysbiosis? Well, as I've already shown in the previous video, even the authors of the paper you used to claim that SIBO is just dysbiosis said this: SIBO does not correlate with small intestinal microbial dysbiosis. We compared the microbial composition of symptomatic patients with and without SIBO, and found that SIBO does not correlate with small intestinal dysbiosis. This suggests that some symptomatic patients diagnosed with SIBO in fact have an overabundance of bacteria normally found in healthy microbial communities, whereas others who do not have SIBO based on quantitative assessment have dysbiosis as defined here. So there is widespread consensus within the literature that SIBO is an issue, and that it is an excessive accumulation of bacteria in the small intestines that is the problem, and not dysbiosis as Dr. Greger would have you believe.
It's typically treated with antibiotics. But dispensing antibiotics to patients with such non-specific common symptoms is not without risk.
OK, that paper that Dr. Greger is citing is one we pulled apart earlier, and the conclusion, just to repeat, was regardless of the diagnostic approach, the foundation of treatment is the conscientious and discerning use of antibiotic therapy, along with eliminating or altering predisposing risk factors as able. So at the end of Dr. Greger's clip there, you heard him say that taking antibiotics is not without risk, so let's see how he defines that risk.
You could be fostering antibiotic resistance, there could be side effects, and wiping out your good bacteria could set you up for an invasion of bad bugs.
Okay, saying there is a risk is a pointless statement to make like Dr. Greger is doing there, unless you tell people what the risks actually are. I have a risk of getting hit by a car whenever I cross a street, but is that an actual big risk factor? Does the benefit of crossing the street outweigh the risk of getting hit by the car? Absolutely. And this is the problem with Dr. Greger's fear-mongering here. Telling someone who is treating SIBO with antibiotics that they might get a C. difficile infection and not telling them the risks is absolutely absurd. C. difficile is a bacterial bowel infection that causes diarrhea, gas, bloating and other gut problems, and in rare situations can cause loss of life. So the CDC has written articles like this one that say nearly 500,000 Americans in 1 year caught C. difficile. So what Dr. Greger is saying here, that because a lot of people get C. difficile infections, you shouldn't treat SIBO infections with antibiotics. These people should simply eat more fibre. 500,000 people is a lot, but unless you understand these numbers, what good is that for assessing whether it is safe for you to take antibiotics for SIBO infections? And please listen to the next couple of minutes because this is super important. 350,000 patients out of the 500,000 patients who develop C. difficile in America develop the infection while in hospital, and according to the CDC, studies have shown that 30 to 50% of antibiotics prescribed in hospitals are unnecessary or even incorrect. The CDC also says that approximately 2/3 of the C. difficile infections were found to be associated with an inpatient stay in a healthcare facility, but only 24% of the total cases occurred among patients while they were actually hospitalised. Almost as many cases occurred in nursing homes as in hospitals, and the remainder of the healthcare associated cases occurred among patients who were recently discharged from a healthcare facility. So let me just break this down for you. 70% of all C. difficile cases were associated with people in or around a hospital or care home setting. Also, approximately 2/3 of these people were 65 or older. Only 30% of people who take antibiotics from their doctor or GP develop C. difficile infections, and the CDC says this regarding these people. Although more than 150,000 of the 500,000 infections in the new study were community associated and thus had no documented inpatient healthcare exposure, a separate recent CDC study found that 82% of patients with community-associated C. difficile infections reported exposure to outpatient healthcare settings, such as a doctor's or dentist's offices, in the 12 weeks before their diagnosis. This finding underscores the need for improved antibiotic use and infection control in these settings as well. It is estimated that more than 50% of antibiotics are prescribed unnecessarily in outpatient settings for upper respiratory infections like cough and cold illness, most of which are caused by viruses. So the CDC in the country where Dr. Greger lives says that a high proportion of people who develop C. difficile do so in a hospital setting where misuse of antibiotic occurs in patients who are elderly, frail and often with compromised immune systems. So remember, Dr. Greger says you shouldn't treat SIBO infections with antibiotics because you may develop these types of dangerous infections. So just 18% of the 150,000 people who develop C. difficile infections did so out of a hospital or nursing home setting, so that is just 27,000 people. So in America, antibiotic prescription rates have been as high as 270 million prescriptions. That's enough antibiotic courses for 5 out of every 6 Americans on average to receive an antibiotic prescription. So that's 270 million prescriptions and just 27,000 people or so who develop C. difficile outside of a hospital setting where the vast majority of people were elderly and frail. And the biggest variable in this discussion is the type of antibiotic taken. Now, there are very few longitudinal cohort studies that have looked at antibiotics and C. difficile, and one of the most recent, which is a very good study, was published by Kenin Brown et al. In 2020. They conducted a longitudinal case cohort analysis representing over 90% of Ontario nursing home residents between 2012 and 2017. Of the 1,708 patients who developed C. difficile, they concluded that C. difficile infection risk increases with antibiotic duration, and there are wide disparities in risks, associated with antibiotic courses used for similar indications. So the main group of antibiotics that were causing C. difficile infections were strong broad-spectrum antibiotics such as clindamycin and fluoroquinolones such as Cipro. They certainly weren't the antibiotics used to treat SIBO infections such as rifaximin, neomycin and metronidazole. Now look, I'm not saying that antibiotics are not without their problems. I am someone who had a severe adverse reaction to an antibiotic due to a genetic mutation and lost 6 years of health to them, so I know just as well as anyone over their potential problems. But massively overplaying the risk for something like C. difficile for people treating SIBO infections using antibiotics like rifaximin, where there is very minimal risk for those under the age of 65, is something I really don't get from Dr. Greger. And remember, you don't always have to use antibiotics. You can use natural antimicrobials if you are concerned about the small risk factors of something like C. difficile. Now, I've obviously just focused on C. difficile infections, and there are obviously other issues such as bacterial resistance and side effects of antibiotics, etc., but you have to give people the facts and not scaremonger. For someone who is young, i.e. below 65 years of age, and is taking something like rifaximin to remove SIBO infections, the risks of something negative happening are very small indeed. Base your decision to take antibiotics to treat SIBO on the known risk factors and your own health and age status, and not on overgeneralized fear mongering.
Like C. diff, all for a condition that may not even be real.
So you just heard that citation there, where Dr. Greger was using it in an attempt to cast doubt on SIBO as a condition. Again, this is simply cherry picking. He has taken a statement out of the paper where the author is simply saying that some people don't believe that it is an actual condition. Again, it is clear that Dr. Greger did not read this paper because the author of the paper is Dr. Michael Ruscio, whose conclusions in the paper were testing and treating for SIBO can offer patients clinically significant relief. However, these tests and treatments must be applied with circumspection to prevent over-testing, over-treatment, squandering of resources, or creating a fear around certain foods.
Even alternative medicine journals admit that SIBO is being overdiagnosed, creating confusion and fear. SIBO testing is overused and overly relied upon. Diagnoses are often handed out quickly and without adequate substantiation. Patients can be indoctrinated into thinking SIBO is a chronic condition that cannot be cleared and will require lifelong management. This is simply not true for most, and is an example of the damage done by overzealousness.
I would agree with all of that, but for the last 4 years, I and many other practitioners have told their patients that for many, treatment is usually short-lived, and as long as they address the underlying causes of their SIBO infection, then they will usually get rid of the problem and be able to get back to a normal and varied diet without too many issues.
The monster that we now perceive SIBO to be may be no more than a phantom.
Again, Dr. Greger is cherry-picking sentences from a paper in order to put a spin on the topic of SIBO. That paper that Dr. Greger referenced is by Dr. Eamon Martin Quigley, who is the past president of the American College of Gastroenterology, and Dr. Eamon Martin Quigley's conclusion in that paper was simply, SIBO, once removed from its original confines as a cause of malabsorption syndrome, has proven to be an elusive and moving target. Only the most rigorous studies employing validated methodologies will finally corral this mysterious entity. All he was doing in the paper was saying that better treatment and testing methods need to be researched to understand the true prevalence of the problem, and I don't think that anyone would disagree with this.
The traditional method for a diagnosis was a small bowel aspiration, an invasive test where a long tube is snaked down your throat to take a sample and count the bugs down there. This method has been almost entirely replaced with breath testing.
Yes, it has, because as demonstrated in Dr. Greger's papers he used in the last video, breath tests are used because they are cheaper, non-invasive, and carry significant less risk than biopsy in people.
See, normally a sugar called glucose is almost entirely absorbed in the small intestine, so it never makes it down to the colon. So if there is bacterial fermentation of that sugar, that suggests you have bacteria up in your small intestine and can detect that fermentation because the bacteria produce specific gases that get absorbed in your bloodstream and then are breathed out from your lungs, which can then be detected with a breathalyzer-type machine.
Yes, that is true that glucose is absorbed very high up in the small intestines, and for many, this has the potential to create false negatives, as a lot of people's SIBO infections are lower down in the small intestines towards the ileocecal valve. So clearly, taking something that is very quickly absorbable into the bloodstream wouldn't be overly accurate, and I don't think that too many people would disagree with this.
Previously, a sugar called lactulose was used, but lactulose breath tests weren't found to reliably detect the overgrowth of bacteria, so researchers switched to glucose. But when glucose was finally put to the test, it didn't work either.
Now, as I've said before, I will pull apart the actual science and accuracy of breath tests in part 3 of this series. Here, though, Dr. Greger has taken one single quote from one single paper out of 774 that exist in PubMed. The quote that Dr. Greger is quoting are from citations 17 to 20. Citation 17 is from a paper from 1990, so 31 years out of date, and the other papers in that citation have a whole host of other problems. The main issue is that these papers and studies are comparing breath tests to biopsies. Clearly, biopsies are the gold standard for determining SIBO, but as stated many times, they are expensive, invasive, and carry many risks that breath tests don't. Nobody is saying that breath tests are 100% accurate. Their limitations are well known, but the benefits of using them outweigh the limitations for many, and until other more accurate tests are available, the overwhelming body of evidence that exists says to use them. Breath tests are used in lactose malabsorption diagnosis, H. pylori infections, fructose malabsorption issues, and SIBO issues. They all have their limitations, but despite this, they are seen as a useful tool for looking at these issues in the gut, and it's why many health organisations around the world are using lactulose breath tests over glucose breath tests for diagnosing things like SIBO. So again, most practitioners are using the lactulose breath test, as the glucose test is known to create false positives in approximately 50% of patients who use it. So Dr. Greger is saying nothing new here. And as discussed, I will go through the up-to-date evidence on breath tests in part 3 of this series.
It turns out glucose can make it down to your colon after all. They labeled the glucose dose with a tracer and found that almost half of the positive results from glucose breath tests were false positives, because they were just fermenting it down in their colon where your bacteria are supposed to be. So patients incorrectly labeled with SIBO may undergo multiple courses of antibiotics for a problem they don't even have.
And the final point there that Dr. Greger made is people being given antibiotics unnecessarily when they don't have SIBO. So breath tests are a tool that are used to look at the excessive amounts of fermentation and gases produced in the small intestines and also in the colon. Practitioners will use them along with discussions with their patients on their GI symptoms such as gas and bloating to determine what action should be taken. But let's say hypothetically a person received a false positive SIBO result from a lactulose breath test because of colonic fermentation. Regardless of whether the issue is in the small intestines or colon, there is excessive bacteria that is causing excessive gas and bloating that will need to be resolved and addressed. So nobody is saying that these tests are 100% accurate. They should simply be used as a tool alongside a person's history of gut issues to try and help the patient resolve or improve their GI issues. Unfortunately, eating more fibre, as Dr. Greger said in his previous video, does not help many.
Why do experts keep recommending breath testing then? Oh, you mean the experts at the conference supported by a breath testing company, most of whom had personally received funds from SIBO testing or antibiotic companies?
This is right to point out, where practitioners are actually using these tests fraudulently to make money and also to push antibiotics to make money. You can't label everyone with this brush though. I live in a country where healthcare is free at point of entry and SIBO tests are used alongside antibiotics because they are effective for many at improving or resolving gastrointestinal problems, and they are also free.
And even if we could properly diagnose it, does it even matter? In those with digestive symptoms, there is a range of positivity for SIBO from approximately 4% to 84% all over the map, and there may be no difference in symptom scores between those testing positive versus those testing negative, so testing positive could mean anything.
I covered this off in my last video. There are many diseases such as H. pylori or C. difficile infections where having more bacteria in the infection won't always increase the severity of the symptoms. So asking people to score their own symptoms and then waving this up in the air as some sort of proof is absolutely absurd. But again, I covered this point off in my last video, so watch that if you haven't already done so.
Now, antibiotics can make people with irritable bowel type symptoms diagnosed with SIBO feel better, so doesn't that prove SIBO was the cause? No, because it can make just as many people feel better who are negative for SIBO.
Again, this is a pointless statement to make, and it's cherry picking. Yes, there are limitations of testing, but if a person receives a false positive for SIBO and they have excessive fermentation in the colon and not in the small intestines that improves when they are taking rifaximin, what does it matter if they get better? And this is exactly what the study concluded that Dr. Greger was using there to bash SIBO testing. Although a perfect breath test for SIBO is currently lacking, the 2017 North American Consensus document offers clinical direction regarding choice of substrate, testing methodology, and interpretation of results, which requires further refining as new evidence emerges. Breath testing is considered a safe and non-invasive diagnostic tool for SIBO, although gaps in knowledge regarding the optimal methods of performing and interpreting breath tests remain. So again, Dr. Greger is bashing the testing, but even the authors he is citing and cherry-picking quotes from recommend breath testing.
Currently, rifaximin is most often used for SIBO, but it's not FDA approved for SIBO, so the cost can be prohibitive. In fact, no drug has been approved for SIBO, so even if you have good insurance, you may be shelling out of pocket as much as $50 a day, and you typically take it for 2 weeks.
Actually, Dr. Greger, although no FDA-approved medication exists for the treatment of SIBO, rifaximin has recently received approval to treat diarrhea-predominant IBS and patients with methane-positive SIBO breath tests. It is also recommended in the UK for the treatment of SIBO, which is free of charge for many, and the science is evolving, as are the recommendations.
And while antibiotics may help in the short term, they may make things worse in the long term. Those who are given a course of antibiotics are more than 3 times as likely to report more bowel symptoms 4 months later than controls. So what can we do for these kind of symptoms? That's exactly what I'm going to turn to next.
Again, that is an absurd statement to make. There are so many variables in his statement. So if I take doxycycline or fluoroquinolones, which are very powerful antibiotics, clearly they have the potential to create additional digestive complications, such as gastritis and ulcers, and these are well demonstrated in the scientific literature. But to compare these types of antibiotics to rifaximin or other antibiotics that are used to treat SIBO that have a very good safety track record is again very bizarre. Also, the study that Dr. Greger is using doesn't take into account any of these variables. So if I have gas and bloating and take an antibiotic and my gas and bloating go away, and I continue to eat a poor diet, what do you think will happen to my symptoms moving forward? Yes, the problems are likely to come back. This is cherry-picking data of the highest order. And his suggestion in his follow-up video for people with gut issues was simply to eat more fibre, and we've already seen in his comment section how little this is working for people with SIBO type of problems. Anyhow, if you enjoyed this video, then be sure to check out this one up here because I'm sure you'll find it equally interesting. And the only other thing that's left for me to say is to remember to look after your body because it's the only place you have to live. And I'll see you next time.